All of you know Dr. Tiffany Swan, who is a medical oncologist with Diablo Valley Oncology and one of our local breast cancer experts. So welcome, Dr. Swan.
Thank you, Margaret, and thanks to all of you guys for coming out on a Saturday morning. This is our 6th year of doing this program, and on behalf of Diablo Valley Oncology, we thank the cancer support community and the American Cancer Society for partnering with us so we could bring this to Walnut Creek. And this program, it's sort of a hodgepodge of a few different things we'll be talking about, but the whole umbrella of it is to really address breast cancer survivorship. And that really encompasses a lot of different topics. Every year we mix it up a little bit, have different panelists. And what I'm going to be talking about today as a medical oncologist is some of the updates in breast cancer treatment that have come out in the past year or so and change. And it's a short topic, a short talk, and I could really do a lot more with each of these, but we can get into things a little bit more during the Q&A also. So what I wanted to do, let's see, we have some slides here. So this is my token breast cancer statistics slide, and I update it every year. I think it's always a good way to frame why we're all here today. And we all know that breast cancer is the most common cause of cancer in women, and it's the second most common cause of cancer death in women, second to lung cancer. And all of these are actually still behind heart disease. I always think it's important to mention that. So the statistics that are up here, they do change a little bit every year, but not too much. And so when I updated this slide, we know that in last year, 2013, we had 230,000 women diagnosed with breast cancer in the United States in 1 year. So that's a lot of women still being diagnosed with this disease. The mortality or the death rate from breast cancer is over 40,000. That's actually gone down over the past few decades. So we do see, even though that's a lot, that is slowly going down. And we attribute the decrease in mortality to better treatments, which is some of what I'm going to talk about today, some of the updates, and also the fact that we are able to pick up breast cancer at earlier stages when they are curable, and that is due to the screening programs that we have in this country. So my favorite number always is the bottom line there. So 2.8 million breast cancer survivors in this country right now, and you guys make up part of that. 2 years ago, I guess, when I put up a slide like this, it was 2.6. So we're going up with the survivors, and that's pretty amazing. So what is a breast cancer survivor? And you returning folks have seen these slides before. So there are a couple of definitions for what a breast cancer survivor is. The National Cancer Institute says that an individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. Family members, friends, and caregivers are also impacted by the survivorship experience and are therefore included in this definition. So in this room, we have people who are currently undergoing treatment for breast cancer. We have people who have completed their treatment and are a few years out or decades out. And we have loved ones, family members, friends, and then we have people who are involved in the health care on the professional side of breast cancer. So we have a lot of people from a lot of different areas, but we're all here for the same reason. What I'm not going to address as much during this talk is sort of quality of life issues of women who have gone through breast cancer treatment, but my co-panelists are going to talk about that a little bit. But it's not just that you live, it's how you live. So we want not people to just be surviving their breast cancer, but to have an excellent quality of life. And that's always very important as we look at how we treat our patients. So I have 5 trials that I picked out that I wanted to talk about. I'm probably actually going to skip over one of them in the interest of time. There's always a lot to talk about. Breast cancer is such an active field of research. There are so many drugs being studied at any given time. And over the past few years, a lot of new drugs have been approved by the FDA, and it's been very exciting. So I wanted to touch on some of these. So the first trial I'm going to talk about is the ATLAS trial. This does not involve a new drug at all. This involves a very old drug that many of you know and love, maybe, called tamoxifen. And tamoxifen is an estrogen blocker. So I'm just going to review, because I don't know where everybody's at in their background of breast cancer, but about 75% of breast cancer is sensitive to estrogen, which is the female hormone, and or progesterone. So a majority of breast cancers are they actually use estrogen as sort of their food source. And so the mainstay of treatment for this type of breast cancer is the blocking of estrogen. And this is done in both early stage breast cancer, when we're trying to prevent recurrence, and in breast cancer that has already spread, metastatic breast cancer, we also use estrogen blockers all the time for treatment. And there are two kinds of estrogen blockers. We have tamoxifen, which can be used in a woman of any age, whether they have gone through menopause or not. Tamoxifen blocks estrogen from wherever it's coming from in the body. And then we have the aromatase inhibitors, which many of you are also familiar with. And those are Aromacin, which is exemestane, Arimidex or anastrozole, and Femara, which is letrozole. And there are 3 drugs on the market right now. And those are estrogen blockers that work only in women who have gone through menopause, so who do not have their ovaries still working. So this trial, the ATLAS trial, looked at tamoxifen. And this was presented, actually, this is a little bit older. This was presented at the San Antonio conference that I go to every year and in December of 2012. So we're looking at almost 2 years. And this trial we'd been waiting for this for a long time. And what it was is that the standard treatment of tamoxifen in someone who has early stage breast cancer is for 5 years. And what they had previously shown in all the studies was if a woman takes tamoxifen for 5 years, the recurrence of breast cancer goes down over the next 10 to 12 years. So you take the drug for 5 years, but you actually see decreased recurrence out to 10 to 12 years, which is a long time. But we also know that breast cancer can come back later. And this is one of the kinds of cancers where you reach the 5-year mark and you don't get the all clear like you do with some other cancers, because we know that breast cancer, particularly the hormone-positive breast cancers, can come back out to 15 years. And so what this trial was looking at is look at 5 years of tamoxifen, which is standard, or 10 years of tamoxifen. And they randomized, as you can see, almost 7,000 women. This was a huge trial. It was very well done, very well controlled. And what they found is that in women who take tamoxifen for 10 years have a 30% decrease in their mortality from breast cancer. That's huge. That's a pretty big number. And what they specifically found is that this happened in the late recurrences, the past 10 years. So they really found a difference in breast cancer recurrence from years 10 to 14. So this looks like this is going to be what makes a difference in women not getting breast cancer back later. So we know we can do a pretty good job with the first several years, but this is going to help us do a good job with those late recurrences. The problem is that not everyone will have a late recurrence, and it's not a common event. And we are committing a lot of women to taking a long amount of treatment for what may not help them specifically. And so what's going on in research right now at a molecular and genomic level is trying to figure out if there are tests that we can do to a woman's tumor to be able to predict who's going to be a late recurrer and who should take tamoxifen for a longer time. So that's something we may be hearing about more in the next few years, because those tests are going to be becoming available, we hope. Because it is a lot of treatment. And for those of you who are on estrogen blockers, know that it can really affect your quality of life. And sometimes it's hard to even get to 5 years. So asking someone to go on to 10 years is sometimes not that easy to do. But what this did really turn into is a 2.6% improvement in mortality, which doesn't sound like a lot to you, but when you think about the hundreds of thousands of women who have breast cancer, that's a lot of lives saved by taking by taking tamoxifen for a longer time. So that has become the standard of care for tamoxifen, 10 years, and this was considered a practice-changing trial that came out. So it now begs the question of what we do with our patients who are on the other estrogen blockers, which are the aromatase inhibitors, and many of you are on those. So there's a study going on right now called the MA17R trial, where they're doing the exact same thing. They're taking women and putting them on aromatase inhibitors for 5 years or 10 years. And we anticipate the results of that study to be out maybe even within the next few months. So we're waiting for that. And what isn't clear at this point is it that we just want to block estrogen for 10 years, doesn't matter what the drug is, or is this specific to tamoxifen? So we'll know that soon. And what I'm doing with my patients now who are getting to their 5 years of aromatase inhibitor, and we have to decide, do we go with the data that tamoxifen is better for longer? And it's really an individual decision. And so I talk to my patients about what their side effects are, if they're having problems with bone loss, because we know that osteoporosis is a risk with aromatase inhibitors. And some women who are doing very well on their aromatase inhibitors want to continue beyond 5 years. And some say, I am done. Until you can prove to me that it's going to be better, I'm not going to do it. So it's really an individual discussion between a patient and her physician. So maybe we'll have some more of that data by the next time we talk. So sorry, that was a long time of talking. I'll try to get through the other ones. Oh, I did want to mention one more thing. Tamoxifen does have a risk that we don't like, which is that it can increase the risk of uterine cancer. It's a very, very small risk, and one of the concerns when we put women on it for more than 5 years was the risk going to go up? And it did just a tiny bit, but really not enough to be considered statistically a problem. So the risk of uterine cancer developing from tamoxifen is about 1.6% for women who take it for 5 years, and it's double that, 3% for women who take it for 10 years, but the mortality, the death rate from uterine cancer is very, very low because uterine cancer is very curable. Most women can have a hysterectomy and be done with it. So the death rate is only 0.2 going up to 0.4%, so that has not been considered a reason to not take tamoxifen for a longer time. And I'll just go through that quick. Okay, so I want to talk about the HOPE trial. This was a small study that I thought I was sitting in on the presentation of it in Texas last year, and it's just a few hundred women, but it's very relevant to a lot of people in this room. So we know that one of the most significant side effects of being on aromatase inhibitor drugs to block estrogen is that it can cause joint symptoms. And the studies show anywhere from 25 to 50% of women will have some kind of symptoms in their joints by being on these medications. And it does not damage the joints in that when you stop the medicine, the joint pain goes away, but it can really affect quality of life in some women. Most women will say, I feel stiff, my joints are achy in the morning, I feel older, but once they get moving, they lubricate their joints, they're okay. But there is certainly a group of women who actually have pain and actually have an impact on their quality of life to be on these medications, and that is the number one reason that women stop taking their aromatase inhibitors. So they did a very nice study where they took women who were having pain, joint pain from aromatase inhibitors, and randomized them to either their usual activity, which you can imagine is a pretty wide range, versus specific exercise program for a year. So the usual activity group, you'll get all sorts of things. You'll get people who don't exercise at all. You'll get people who exercise a lot, but hopefully it all sort of balanced out. But in the exercise program, women did 2.5 hours a week of aerobic exercise of a moderately brisk pace, so they got their heart rate up, and they did 2 times a week of strength training. And what they found is if the women adhered to this program for a year, their joint symptoms got better by about 30%. So a nice little study and a nice way for us to push exercise even more on all of you guys. And I just wanted to mention that. Okay, I wanted to talk about this trial called the Cleopatra trial, and this made some big headlines this year, which is why I think it's important to just bring it up briefly. I actually talked about this 2 years ago at this program when they had the initial results of this trial, and now we have the final results, and it's been very exciting. So what this is for women who have HER2 positive breast cancer. So this is different than hormone positive breast cancer. This is a different type of breast cancer. HER2 is a gene and a protein on certain breast cancers, about 25%, that makes for a more aggressive breast cancer. And in 2005, they showed that if women used a drug called Herceptin, that they would decrease their mortality, they would improve cure rates by 50 to 60% with a drug called Herceptin. And Herceptin is not chemotherapy, it's an antibody against this protein HER2. And so I'm sure several of you in the audience have been on or are on Herceptin. So Herceptin is the standard treatment for HER2 positive breast cancer and is given with chemotherapy initially. But it doesn't work 100% of the time. And we know that because it is aggressive tumor, if Herceptin isn't working, we needed to find some other treatments. So this drug, Perjeta, was approved by the FDA about 2 years ago. It's also known as pertuzumab, and it's another antibody against HER2 that works synergistically in combination with Herceptin and chemotherapy. So what I presented a couple years ago was there was a lot of excitement, and what led to the FDA approval was they showed that in women who took Perjeta with their chemo and their Herceptin had a slowing of the progression of their breast cancer. So these are all women who actually have active breast cancer, stage 4 breast cancer. Okay, that's different than the upfront curable treatments. And that was a pretty big deal to see a change in progression-free survival is what we call it. And so the FDA was very excited, and we added Perjeta to our armamentarium of treatments.
So now what they have is the final analysis where, we're excited when we see that breast cancer doesn't progress very quickly, but what we really want to see is an overall survival. And so what we're seeing now is a 15-month survival benefit when you add Perjeta to these patients. Oh, it's upside down. Somebody's playing with me. Okay. And, I don't know how 15 months comes across to you guys, but in someone who's living with stage 4 breast cancer, over a year of life is a big deal. And so this drug is really now going to be on the forefront of treatment for HER2-positive breast cancer. I have treated some patients with it. It is a more difficult drug than Herceptin. It can cause some side effects, not as bad as chemotherapy, but it can cause a lot of diarrhea, some rashes. And it does have some more side effects than Herceptin does, but really, really makes a difference in the life of these women. They are actually looking now at using Perjeta in upfront treatment of breast cancer. So in that early stage breast cancer, when women have HER2 positive and are now getting chemo and Herceptin, they're now studying in a trial called Affinity to see if adding Perjeta at that point will improve the cure rates. So we'll see where that goes. And we've also shown that when we give it with chemotherapy for neoadjuvant treatment, which means when we're giving chemotherapy to a patient who has a tumor in their breast and we're giving the chemo before the surgery, when we add Perjeta, we increase what we call the complete response rate, so that when we go in and do the surgery, the cancer is all gone. And that happens more frequently when Perjeta is being used. So really a big drug, and you guys will hear more and more about it. And then the last thing I'll talk about, way over time, is a Paloma trial, which was released this year. And because of this trial, we're expecting an expedited FDA approval of this new drug called palbociclib. And this is also a study that's looking at women who have stage 4 metastatic breast cancer. These have HER2 negative breast cancer, hormone positive. Okay, so these are women who would get aromatase inhibitor drugs. In this trial, they used letrozole or Femara. And then they use this new drug called palbociclib. And palbociclib is not chemo. It's a targeted agent. It's what we call a biologic drug. It's a pill. So this is a pill, all oral regimen. They take an oral aromatase inhibitor and a pill, palbociclib. And palbociclib interrupts it's called a cyclin-dependent kinase, which is a protein that actually allows cancer cells to rapidly proliferate and grow. And this blocks one of the steps in that pathway. And so in this Paloma trial, they found that in women who took the combination had 20 months of slowing of the progression of disease versus 10 months if you didn't take the drug. So that's a big difference. That's a doubling in what we call progression-free survival. So everyone's very excited about this drug. I have a bunch of patients who are waiting for it to be approved. And when I made the slide, I had heard that it was going to come out by the end of this year, but the more recent update is probably April of 2015. They're waiting for the FDA final approval. So those are the things I wanted to touch on. Again, I'm happy during the question and answer period to go into these a little bit more or address some other issues. And now I'll have to share the podium. Thank you so much.